ask you about what sorts, because headaches are what we get particularly concerned about. I think patients get very concerned as well. What sorts of headaches are you concerned about, and how can we differentiate different sorts of headaches?
Yeah. So the question when faced with a patient presenting with a headache is whether it's a primary headache disorder, which are headache disorders not related to an underlying disease process like a brain tumor or inflammation or meningitis or encephalitis or anything like that, but a condition by itself. And the primary headache disorders most commonly are migraine, less commonly cluster headaches, paroxysmal hemicrania, and various other less common things. But the vast majority of headaches that people present with in primary care, and in fact the bulk of our workload as general neurologists, is actually migraine. And the key thing really is to be able to distinguish between primary headaches, mainly migraine, and secondary headaches, which are caused by underlying diseases like brain tumors. And it's all really in the history. So migraine headaches are typically frontal. So most people who have a headache towards the front of the head eventually turn out to have migraine, unless they have an ENT cause like sinusitis. And they are typically throbbing in nature and associated with nausea or actually vomiting, and photophobia, intolerance of bright lights, have to have the curtains drawn all the time, and photophobia, they are intolerant of loud noises, so people have to turn the TV down and not make any banging noises when mom or dad has a headache. And very typically it's made worse by any sort of movement. So people with migraines very typically like to keep still. So they take to bed, they have the curtains drawn, they have the covers over their head, and they just lie as still as they can until the thing passes. And lying down eases the headache. So that's the kind of history which will reassure you that the headache that the patient is reporting is in fact migraine, and therefore is not going to have an underlying cause. And even if they have a scan and something shows up on the brain MRI scan, it is an incidental finding. It's got nothing to do with that patient's headache, and treating that is not going to make that patient's headache better. So it's really about obtaining that history and being confident in the clinical diagnosis of migraine. So one has to bear in mind that brain tumors are in fact pretty uncommon, and most GP practices will have maybe 1 or 2 patients with it. And if you bear in mind that it is a very small minority of that very rare condition that's going to present with raised intracranial pressure type headaches, then it's highly unlikely. And in fact, my colleague who runs the specialist headache clinic texted me yesterday saying for the first time ever in his 20-year career, he saw a patient referred on the 2-week pathway with raised ICP type headaches, actually had a brain tumor, but they also had really prominent papilledema on examination. So there was a pretty clear clue there. So headaches on their own as a presenting feature of a brain tumor would be incredibly uncommon. And if they do have raised intracranial pressure headaches, then they tend to be worse in the mornings. So lying down actually makes that headache worse, which is the opposite of what happens in migraine. And obviously through the night you're lying down for many hours, and typically that headache will be worse in the morning. And standing up, walking around for a bit makes it a bit better. Then typically Valsalva type maneuvers of bending, stooping, coughing, etc. is said to increase the headache in someone with raised ICP. And it does happen if you really have raised ICP, but it also happens in migraine. So if you ask a patient with bad migraine, what happens when you bend or cough or sneeze, they will say it makes it worse. But that's just part of the whole movement aversion that these people have, and not part of, not indicative of raised ICP. The key thing to look out for is really whether they have progressive neurological symptoms, as Catherine said. And these could be something very obvious like weakness or speech disturbance, but it could be something very subtle like inattention and dyspraxia. So inattention would make you bump into door frames, be less good at driving, scratch the car, one side of the car, clip wing mirrors, and unable to reverse parallel park, etc. And if those things come to light, and particularly if in a few weeks it's progressed, then and typically on examination you may find that there is some lateralized weakness or an upgoing plateau or something like that. Those are the things that would make you think, yes, there is something going on here. So the key thing really is to be able to distinguish between primary headaches, particularly migraine, and a headache plus syndrome, where you have somebody with a new onset of headache which does not have migraine features and is associated with progressive neurological deficits.
So is it useful to check visual fields in those patients? The ones who've got progressive, and we've got somebody who's said that they've had a few accidents or they've bumped the car or...
Yes, a basic neurological examination is mandatory in all patients presenting with a headache, and that includes visual field testing by confrontation, as well as examining for papilledema and any limb weakness and reflex asymmetries and things like that. But I have to say, in most cases, if there is a significant lesion causing those symptoms, the history really is enough to have a high degree of suspicion, so you can refer the patient even if you don't have any abnormal findings on that.
And you're saying that the classical sort of raised intracranial pressure, red flag alarm bells that we're sort of taught almost as medical students is not
it's
common
incredibly rare.
presenting.
It's one of those things, like classical presentations that we're taught in medical schools of all sorts of things. It's actually pretty uncommon. And in fact, I've never seen one. I asked Adam Zimansky, who is my colleague who runs the regional headache service, and he deals with the primary care headache referral pathways and things like that. Has he ever seen one? He's seen one in 20 years. So it's actually, almost like a case report if it happens. Somebody presenting just with raised intracranial pressure and nothing else.
When you get this,
carry on, Catherine.
I was just going to say, when you do get those symptoms of raised intracranial pressure, it's as the crescendo of lots of other things that have built up to that point. For it to jump out, as Rajiv said, for it to just occur on its own out of the blue is just unbelievably rare. And it's when, if somebody is presenting with that, then you drill down into the history, and actually there were numerous other things leading up to that point. And so really, as Rajiv has said, for that to be an isolated thing is incredibly uncommon. We need to be asking different questions.
Right, okay. So what sort of other, I think you've mentioned it a little bit, but Rajiv, what other symptoms would we be looking out for?
So the thing that, as Catherine said, that the symptom that patients with brain tumor present with classically would be a seizure. So a seizure is the one thing that would make me worry that an adult patient presenting with a seizure, you really need to do a scan to exclude an underlying tumor.